So, Bastian, I want to ask one question first. I know I can, yeah, I can understand how internal rotation, external rotation improve because you reattach the tendon insertion, but how the shoulder abduction or elevation improve after tendon transfer? The mechanism, let me know.
You know what? I will show it in the next debate. We will have it, but because originally when we described it, it was for brachial plexus, and this is no debate. We're just talking about brachial plexus. Brachial plexus has nothing, and they want just ER. So when you have no deltoid, no subscap, nothing, you can do lower trapezius. This originally. Then when we start to do it for the massive posterior superior rotator cuff, you insert the tendon on the supraspinatus footprint. It gives both compression and external rotation. So for me, the main indication, yes, it gets you external rotation, elevation. I'll show you some cases. It does the job. It does the job. If I have massive rotator cuff tear, I promise I will let Philippe Valenti do lower trapezius on me.
Thank you very much. And as a presenter, any comment?
Yeah, about the abduction improvement. I mean that the abduction is quite a little bit combined using the scapula protracted in the forward deflection in the plane of the scapula. So this is not just a humeroscapular movement, but is a combined scapulothoracic that improves tendon transfer, the lat dorsi in this case, to improve the abduction, that is mild forward elevation.
Okay, yeah, that's a good idea.
Abduction is not a goal for me.
Oh, okay.
It's not a goal because when I see a patient, I don't recommend to do abduction because there is an impingement.
Okay.
Abduction is useful if you have external rotation. But for me, the most important is to restore anterior forward elevation because there is no risk of impingement with the acromion. And in this kind of shoulder, many times the biomechanics change. And when they do abduction, they are not able to do external rotation, and they are painful. And when I see my patient in consultation, I don't recommend to do abduction. I recommend to do forward elevation on external rotation. It's not a goal for me.
Okay.
So biomechanically, if you take a shoulder, normal shoulder, which we cannot do, of course, in life, and you try to cut the supraspinatus out, and you ask the patient to flex, they will have some weakness early on, but they can flex because, may the force couple be with you, that's what you say? Because the force couple, because the subscap go proximal, infraspinatus go proximal. Right. And they really hold it very, very well. So it's extremely uncommon to see someone who has supraspinatus only and you have proximal migration. If you have completely intact subscap, completely intact infraspinatus. Okay. This is the idea. The idea is really, really trying to restore the force couple. So,
okay, Rabbi.
The important point is that you have to have a good subscap. If you do this, and it will work perfectly. Again, you have to have a good subscap when you do the lower trapezius transfer, and then you have good elevation because again you restore the false couple.
No, yeah. I agree. And this is why, again, for me, for the SCR, I have an issue with the indication. Like the Mahata's outcome, nobody can reproduce his outcome. His outcome are outstanding. I mean it. Nobody can see 0% rupture, 0% re-tear, and nobody can get this. This is amazing. But I'm talking about indication because you cannot have someone who has no teres minor, no infraspinatus, massive rotator cuff tear, you say, yeah, you can do SCR, you're going to restore function. But I can say if, yes, you do a repair of the infra and subscap, you have this defect, you do it, then you have the force couple and you're connecting them, and I think these are the one, in my opinion, they're going to get the best result. You agree, right?
I think you're completely right. I mean, it's a great idea, but if you don't repair the front and the back and again restore the false couple, it will not work.
Yeah, I agree.
I suppose that the superior capsular reconstruction indeed is useful because gets the infraspinatus, prevents the infraspinatus gliding below the humeral head. Because otherwise, when you abduct or flex the arm, that superior capsular reconstruction, the new capsule gets loose. And so why the function? Probably because there's some support to the position of the infraspinatus.
There is an important point because if you have a good subscapularis, if you have a good teres minor, but a weak deltoid, the shoulder doesn't work. It's not enough. And many times, if you do a very well physiotherapy, you restore a good function of the shoulder. You have a massive posterior superior cuff tear, but you have a teres minor, subscapularis, on a good deltoid, and the patient is very happy. And there is no indication of tendon transfer or capsular reconstruction.
Yeah, I agree.
And I think that many times we talk about the cuff, but the cuff is not alone. There is a deltoid, and we have a lot of patients with no cuff, good deltoid, and no pain. And I think that the main examination is very important. Not only the MRI or what you find during the operation. Most important is the preoperative examination.
So there is a question there from the...
Thank you. I just wanted to make a small statement. I'm a physiotherapist, and very often we have publications and also clinically see people with full thickness tear and have a functional arm. So anatomy is not equal with functionality always. Of course, sometimes it's there. My question to Dr. Valenti is this. After 6 weeks of immobilization, what is your experience with shoulder stiffness and how this is a problem to the functional restoration, rehabilitation in terms of strength, endurance, coordination, and all these functional parameters that we have to take care of? Thank you.
If there is a capsulitis, I treat the patient conservatively. I do free injection on physiotherapy. I continue the physiotherapy because if the shoulder is stiff, it's a contraindication of the operation for me. The result is not so good. And if you do injection on physiotherapy during 3 months, you can restore passive range of motion for 90% of the patient.
Actually, my question is post-operatively. If I understood well, you said that you have 6 weeks of immobilization in a cast.
There is no stiff shoulder after 6 weeks of immobilization in my experience.
Okay, thank you.
So for brachial plexus, I've done at least 400 lower trapezius. For rotator cuff, maybe 100 or 150. What the problem is, and Anna, this is for you as a therapist. Most of the shoulder immobilization with an ultra sling, they're not in ER. In ER, the rotator interval is open. So I think the likelihood of stiffness is much, much less. So in this category of patient, even in older patient, honestly, the number of patients that develop true stiffness is extremely small. And I was trying to think about it why. My only explanation, because you have slight abduction, external rotation, rotator interval is open, with abduction you're stretching the posterior capsule, so post-op, the likelihood for them to develop stiffness is much, much less. It's different than ultra sling, it's different than we put it here. This is abduction, external rotation. I really think it opened everything. And whenever you put them back, the cavity is open, they can reflex more.
Anna, Katarina?
I have a question. We're starting to understand more and more about the role of scapular dyskinesia in degenerative rotator cuff tears. So what do you think that transferring the low trapezius will do to the scapular movement and will contribute maybe to the scapular dyskinesia that these patients have?
You be careful about what you're saying, okay? No, so it's a big topic. I'm not gonna get into it, but I'll get you kind of like the scoop of the matter. Just be careful about you said dyskinesia. What does it mean, okay? Now, when you're detaching the lower trap, what you're doing to it? You're taking a tendon attached on the humerus. Forget about the shoulder. What do you think is gonna happen to the scapula? You're lateralizing, so you're retracting it. This is the best for the scapula. So you're not causing dyskinesia, you're improving it. Because now you're lateralizing your tendon. So it's
That's
retracting.
your theory.
Yes. No, and I can prove it for you. No, but I don't have time, but I can show you. No, it's not only theoretically, no. Me and Ben Kibler, we spoke about it at length. Because you're not taking the muscle out. What you're doing is taking lower trap with the tendon and attaching to the humerus. Even on the table, when you pull, it is pulling the scapula back. So this dynamic effect is both on the humerus and the scapula. And this is why for me, these patients, and you can ask Philippe as well, I don't recall a single patient have any issue with the scapulothoracic motion after lower trapeze transfer.
Thank you.
There is another question.
Okay.
May I ask?
Maybe last question.
I like this lower trapeze because it's an external rotator. Latissimus dorsi, it's an internal rotator. And I've seen my patients with latissimus dorsi, they need a long rehabilitation time because the brain re-education is more in the internal rotator to be an external rotation. So I want to comment for this, for the rehab. And the second thing is, when you do latissimus dorsi, and you think that it's not very long enough, and you have to go in the posterior side, you stay in the posterior or you put a graft and you go over the head?
The lat dorsi is too short just if you do not release enough. It is never short not to put the graft wrapping the tuberosity. So this is a technical issue. And about the first question you gave, so if it is much easier to recover the external rotation firing a muscle that is an external rotator, I agree with you.
Okay, thank you. Maybe the last question maybe we can keep discussing in the next session. Or try? Okay.
I think we can continue.
Okay.
Because the next session is about the same topic again. So we can have questions